Good morning, good afternoon, good evening, wherever you are. I'm very happy to see you here at our ReSViNET webinar. My name is Bont. I'm the chairman of ReSViNET Foundation, and I look forward to a interesting webinar, hopefully. But first, a short introduction of the foundation. Our vision is to connect global expertise and leadership in order to decrease the global burden of RSV infection, with a mission to support high-quality research and to improve knowledge of RSV epidemiology and to develop safe and effective therapeutic and preventive interventions. With the goals to advocate and create awareness for RSV, to act as a focal point for effective partnerships with stakeholders and to combine knowledge and capacity required to enhance development of novel RSV therapeutics. And I think you can see all of this in the webinar in the coming hour. So why do we do this? Research and education. So RSV is an important pathogen that results in 33 million patients, 3 million hospitalizations, 120,000 deaths, almost all of them in low and middle income countries, and most of them occur in the first 5 months of life. So before we move forward with the webinar, I wanted to inform you that we have a very interesting Respiratory Syncytial virus, RSV Vaccines for the World meeting, the 6th that we're organizing, November 10 to 12, where you can register. You can see the website here at our foundation's website, and there's a call for late breakers. So if you have news, please do so for immunology or virology. And there's registration grants. Almost all of them are already taken, but we have a few left for young researchers and people from low and middle income countries. So the ReSViNET webinar series has the objective to promote knowledge sharing of the latest developments and publications on groundbreaking studies, and to provide education to professionals in the field. And we specifically want to address young professionals. We do this every 2 months. And 1 second. Today we have Natalie Mazur, who will be introduced by my co-host, Padmini Srikantiah, who is the Deputy Director in Global Health at the Bill and Melinda Gates Foundation. She leads the RSV team and also the antimicrobial resistance team. And we have been working for many years together, and now Padmini, and it's a great pleasure to have you with us. I'll hand the microphone to you in a second. I wanted to inform you, this is the first announcement of the next webinar on December 9th, which will be on the interaction between RSV and bacteria. And we have created an innovative approach. I cannot tell you who the presenter is on the 9th, but we will have a parallel webinar for parents and the general public on exactly the same topic that will be presented by Dr. Lieke de Frankrijker, who will explain exactly the same information, but now to parents and the general public, so that we can inform not just the professional stakeholders, but also everybody else in the world, in particular, the parents around the world. Just to remind you how many that we have done a lot of webinars. I don't want to take too much time of you, but you can see that we have discussed Science and New England papers and Nature papers over the past 1 to 2 years, with a good amount of registrations every 2 months and excellent feedback evaluations, to which we are very grateful. So just some advice on how to use the icons, the Q&A icons. I'm sure you are used to it. Feel free to raise your hand during the Q&A session and the chat function. We also have a new aspect to our webinar today, that we have the webinar in translated real-time in Swahili, Hindi, Arab, Spanish, French, and if you use the icon interpretation, you can switch to the language to your preference. And we will keep doing that in the coming years during our webinars. So we also introduce a few interactive parts. So I'm going to test that now. I would like to ask you who you are. Are you academic up to the postdoc level, beyond the level of postdoc? Are you employed by industry, public or global health? Are you a journalist or a parent? Are you part of the ReSViNET Foundation or other? You can vote now. So let's have a look. Where do you all come from? Very interesting. So a very good distribution of participation. It's good to see that the poll is working. And it's also good to see that there are no journalists or parents yet, because we have not created the webinar for lay people and parents. So hopefully we will get that in these parallel sessions that we will start from December onwards. With this last question, I would like to hand over the microphone to Padmini. Please take over. Thank you very much.
Thank you so much, Louis. And it's a great pleasure to host or co-host this seminar with you. We're really excited to see these data come out and look forward to today's discussion. It's my pleasure to introduce Natalie Mazur. She is a postdoctoral fellow at the Utrecht University and is also initiating her pediatrics residency there. Natalie has been working on RSV for over the last 7 years with a primary focus in low and middle income countries. And she's been one of the key investigators of the RSV Gold platform, which is a case series of RSV mortality that has brought really important data to the field. It's been my pleasure to work with the RSV Gold team and with Natalie and Louis, and so great pleasure now to turn over to Natalie to give today's presentation.
Yes, good afternoon, good morning to others. It is really a pleasure for me, and more than a pleasure, also an honor to be able to give this presentation on behalf of a very large team of investigators, as well as large investment by the Gates Foundation to investigate RSV-related community mortality. Very, very challenging, but I think also rewarding subject. And I'm excited to share today with you, and I hope you're excited to learn, and hope you can learn something more about mortality in the community, as we recently published in the Journal of Clinical Infectious Diseases. So I would like to start with the why. So why is it so important to understand mortality due to RSV in the community? Well, first of all, as many of you already know, RSV is the second cause of death after the neonatal period in infants. And secondly, most of the burden estimates we now refer to are based on in-hospital studies, because this is much easier to do, obviously. And therefore, community mortality is a largely unknown, unstudied burden. And finally, As you may know, clinical development for RSV vaccines and monoclonals is a very active field currently, with a potential preventive intervention for infants on the horizon. So a very pressing, current, and important issue to understand in RSV prevention. And then I would like to go on to the more personal why. So why is this subject particularly important to me? First of all, in my work in South Africa and Malawi, I was able to see firsthand what life-threatening RSV can look like on the ward, and especially in areas where there's poor access to care. And this for me is really the reason I get out of bed in the morning and keep studying RSV. As you may know, 2 years ago, we created a video, an RSV mortality awareness video of a case of Simone van Wijk, who was brave enough to share her story of the loss of her child due to RSV. In that case, she was able to make it to a hospital. And what we're going to talk about today, or what I would like to discuss today, is the case in which children die of pneumonia due to RSV, but are unable to make it to the hospital. And here is an image that was made by an illustrator with thanks to Dr. Ashish Satav in rural India. And you see here the heartbreaking image of a mother who has her dead infant in her arms. I would like to share the story of a young boy who was 1 month old in a rural village in India. And because the mother you see here was unable to recognize the signs of acute respiratory distress, and because of financial restrictions and poverty, this mother was unable to take her child to the hospital and is now being comforted in this image by traditional healers who are around her. And this is the setting. As I go through, I'll present a lot of data, but I hope this image of a helpless and heartbroken mother who is about to bury her only child, that this is why we are doing this research and why I think it's important. One last thing is a quick disclosure. This webinar is really a small selection of an enormous amount of work done in the field of community RSV-related mortality. So I will not do justice to all the work that all of the collaborators have published. So I encourage you to read our supplement also, but also my apologies ahead of time to those who have done this work, that this will not cover everything that was done. I would like to start with the key learnings and challenges of all of these studies that were conducted. But before I do so, throughout the presentation, I'll have some interactive questions just to see what the audience thinks. So before this supplement was published, the CID supplement, it was estimated that approximately so much % of RSV deaths occur in the community. And the response options are 20, 50, and 80%. So I see that most people responded 50%, and it's kind of a trick question because there is not necessarily a right or wrong answer, because the bottom line is actually that we weren't quite sure. There were a few studies done in which the estimate was probably around 50% of deaths occur in the community. But now that we've done all these studies, we have a much better idea of what percentage of RSV deaths occur outside of the community, and I hope to share this in the next slides. Here you see an overview of the studies that the Bill and Melinda Gates Foundation have supported over the past years. And the goal of these studies was to assess the full burden of RSV in lower middle income countries, with the idea that up until now, we've had a very selective view of what RSV-related mortality means, because it was largely limited by in-hospital studies. And here you see the 5 major studies that occurred, which were all quite different. So some different settings, from rural, very rural, to peri-urban to urban, different methodologies, passive versus active surveillance, and also in different age groups, from infants under 6 months to under 5s. And these different studies also gave different perspectives on the percentage of deaths that occur in the community. I think the important message here is that beforehand, we thought that approximately 50% of deaths occur in the community. And here we see that that's really the minimal end of the spectrum. So at least 50%, if not much more, occur outside of the hospital. There were several keys to success in these different studies, including active engagement of local community members and stakeholders. The importance, as you can imagine, and as you saw in that image, this study is done at an extremely difficult time point for patients and their for children, especially for the parents of the children, and therefore a culturally sensitive approach was essential to be able to conduct studies in such an emotionally challenging period for families. And finally, the importance of grief counseling to offer something in return to these families. There are several limitations, but to name a few of these studies, the diagnosis was largely done by nasopharyngeal swabs of RSV, and as we learned through the minimally invasive tissue sampling, which I will talk about more later, this doesn't always capture the full burden of RSV. And secondly, RSV was always measured at a single point in time. So if it was somewhere in the causal chain, or if you consider 30-day mortality, then certain RSV deaths may have been missed. As I mentioned earlier, you see here a very busy slide, so don't worry, this will be available online later, and I will not go through all of it. But as I mentioned earlier, these studies were extremely challenging to conduct, as you can imagine, due to the setting, but also due to the challenge of being able to reach these children, and also due to the ethical challenges and emotional challenges. So as you can see here, but these difficulties were both logistical and cultural, religious, and other. And some were, for example, related to electricity or very remote locations, and others to being able to train staff to communicate well with the patients. But through all of these challenges, certain best practices emerged, which may help to do further research in this setting. And these include active engagement of local stakeholders, detailed planning of screening and enrollment before conducting the studies, grief counseling during the studies, training staff with communication skills, very multidisciplinary teams with both psychological support, but also researchers, physicians, local stakeholders, nurses, and finally, the transition from nasopharyngeal swabs to minimally invasive tissue sampling in order to better understand what the role of RSV is as a cause of death. And now I will move on to, I hope, some very exciting and interesting findings on RSV-related mortality from these different studies I've mentioned. But first, another question to make sure you're awake. Here in the Netherlands, it's Friday afternoon, and it means most people are already drinking a beer. So I hope at least my Dutch colleagues are still with me. So my question is, risk factors for RSV death are similar in lower middle income countries and high income countries. Is this statement true, A, or false? Give people a few more seconds to respond. Most people say false. Well, looks like people have been reading our publication. No, actually, the truth is that, well, the truth or my answer is that it's both true and false. So certain risk factors are similar and certain are different. And that's what I hope to show you from studies done in Zambia and elsewhere. So I would like to start with the community mortality study performed in Zambia in an urban setting in which RSV positive deaths were compared with RSV negative deaths, both in hospital and in the community. And an important finding was that months of life was a predictor of RSV positivity in death for RSV deaths. And this is important because these are potentially preventable deaths in the first 6 months of life. And then another important finding was that prematurity and HIV, previously identified risk factors for RSV-related deaths, were not found to be risk factors in lower middle income countries. So actually, life-threatening RSV was not limited only to high-risk infants, as previously thought from research performed in high-income countries. Furthermore, in a study in India, in a very rural population with also very high infant mortality, both severe LRTI and very severe LRTI surveillance was done actively in 93 different villages. And when comparing community versus in-hospital case fatality ratios, as you can see here below, it was found that case fatality ratios in the community are significantly, so 7 to 10 times higher than in hospital. So as you can see here, potentially also due to lack of supportive care in cases of respiratory failure, that access to care makes a big difference in whether or not a child dies due to RSV, with both severe LRTI and very severe LRTI. In this study in India as well, there were 11 RSV-related deaths, 10 which occurred in the community and 1 in hospital. And all of these deaths in the end were term children. When the term and preterm populations were compared, it was clear that the burden of RSV mortality was similar in the preterm and term populations, both in the community and in the hospital. Next, I'd like to present some data also from Pakistan. This was data conducted outside of the city, a study conducted outside of the city of Karachi, in the slums of Karachi. And in this population, it was found that post-neonatal age was an important predictor of RSV-related death when comparing RSV positive and negative deaths, as well as respiratory symptoms and RSV seasonality. And this also is in accordance with earlier findings as published by the burden estimates, that deaths that occur in the neonatal period are less likely to be due to RSV, but are more often due to non-infectious causes such as prematurity, asphyxia, and also infectious causes such as sepsis, but less likely to be RSV. Finally, in a study conducted in Argentina in an urban setting in the slums outside of Buenos Aires, there were 63 community deaths identified, 12 of which were RSV positive. And here in this population, the investigators found that RSV does not kill alone, but in fact that this is often together with a bacterial superinfection, more often than not, so in 2/3 of the children who died, and that social inequities are also strongly associated with RSV-related death and a social predictor of RSV-related death. So for example, living in slums or settlements was an important predictor, as well as comorbidities, and not the chronic complex comorbidities we may see in high-income countries, but instead most often undernutrition, a comorbidity related to lower middle-income countries. Finally, also in the study in Argentina, the investigators examined the histopathology of these children in the lungs, and it was found that nearly all, or the majority of these children showed actually a very mild lung histopathology, which was different than expected, and also different than found in higher income countries where the lung histopathology is often severe. In this case, it was 80% had a mild bronchiolitis, meaning that potentially the mechanism of death for these children was different than expected, such as terminal apneas. Another interesting finding to me especially was that children who died in this study, that more than 80% of these children had more than 80% of these parents had visited a healthcare provider at least once. They did not go to the hospital, but had gone to a healthcare provider and been sent back home, indicating maybe that risk perception of physicians may play an important role in whether or not these children are hospitalized more than care-seeking behavior. So now I would like to move on to looking at the role of RSV and RSV-related deaths. But again, start with a question. So in the post-neonatal period, so children from 28 days to 6 months of age, 1 out of how many deaths is caused by RSV? Let's wait for a few more seconds for people to respond. Yeah, I see everyone is still paying attention and actually doing quite well. So after this study, we indeed after these publishing this supplement, we indeed found that 1 out of 15 deaths in the post-neonatal infants was actually caused by RSV, and I will tell some more about that in the next slides. So the CHAMP study was a study conducted in 7 different, and is still being actively conducted in 7 Southeast Asian and African countries, in which the role of RSV in cause of death was examined, and a cause of death panel used both histopathology as well as clinical findings to see whether deaths were attributable to RSV, yes or no. And in this surveillance study, 24 deaths were found to be have a causal role, have RSV as play a causal role in the death. And as you see on the top right here, RSV, actually in blue, in red, those are the deaths that RSV plays a role. And you see, at least in the neonatal period, that RSV is not an important pathogen in terms of cause of death. And 50% of these deaths with RSV as a causal role occurred in the first 6 months of life. In the total population, 6.5% of deaths were with RSV, and a third of these, so 2% overall, were due to RSV, so with RSV as a causal role. Again, RSV did not kill alone, but other conditions played an important role. For example, viral co-infections were present in the majority of infants, as well as comorbidities such as birth defects. When we look at the histopathology, some interesting findings presented in terms of RSV diagnosis post-mortem. In all of the children who died due to RSV, where RSV played a causal role, the lung tissue was always RSV positive when using immunohistochemistry. And in the majority of children, both the nasopharyngeal swab and the lung tissue were RSV positive by PCR. And here you see the lung tissue of a 1-month-old girl who died due to RSV without other comorbidities. And on the left, where you see the arrows, you see multinucleated syncytia. And on the right, you see RSV positive immunohistochemistry strain, just to give you an idea of what these histopathology analyses look like. Finally, I would like to take a more helicopter view. So if we look at all of this data together from a global perspective, does a consistent image of which children are dying who do not reach the hospital emerge? But first, again, a question to you. Globally, children dying in hospital are older than children dying in the community. Is this true or false? Let's do a few more seconds and then we'll show the poll. True, yes. It looks like 2/3 of the people watching say true, and 1/3 says false. And the answer is actually that it's true. Children who die in the community are younger than those who die in hospital. So now I would like to present the data from the RSV Gold platform. This is a platform of using global data sharing to look at RSV-related mortality around the globe. And really gives the opportunity to look at, when you compile all of this data, is there a consistent image that emerges, and also the opportunity to compare community versus in-hospital deaths globally. And in this platform, 166 community deaths were included from 12 different countries, so also beyond these 5 studies mentioned, and were compared to a much larger group of in-hospital deaths, approximately 800 from 38 different countries around the globe. And here you see in purple the different community deaths shared. And here you see the age distribution of children who died in the community in purple and in hospital in green. And as you can see in this density plot, the age is younger, so a median of 1.5 months for children dying in the community versus those dying in hospital, 2.5 months. And this again is very important to understand the potential impact of preventive interventions which can target infants in the first months of life. So I would like to now wrap up with some conclusions. I hope you found this interesting, and again, there's much more in the published supplement, but this gives you a taste of what type of interesting findings and their potential implications. In summary, I hope that I have been able to share with you the importance of the learnings and challenges from these studies. So as they were quite difficult and challenging research. And I hope I've shown you the importance of local engagement of stakeholders and of important community members, as well as best practices that have emerged, such as minimally invasive tissue sampling, which really allow us to look at what is the causal role of RSV. Secondly, I've shared several of the findings from the different community mortality studies in which we see that RSV kills at a much higher rate in the community than in hospital. That risk factors are unique for RSV in lower middle income countries and also unique for children who die in the community. They're generally younger, and children who die in LMICs are not necessarily high-risk children as we know them from high-income countries. And finally, other factors are important in deaths due to RSV, such as bacterial superinfections, so biological factors, as well as socio-demographic factors such as social inequities. These play an important role in RSV-related mortality. Third, I discussed what the role is of RSV in RSV-related deaths. And I shared with you that 1 out of every 15 deaths under the 6 months is caused by RSV. RSV really plays a causal role. Finally, if you look at the global picture, we see that children who die in the community are younger than children who die in hospital, meaning that the potential impact of a preventive intervention in the first months of life is higher than previously expected. So what are the implications of this research? In summary, I think it's important to know that there is a very high previously unmeasured burden. I started with the question, what percent of deaths are in the community? We used to think it was 50%, but now we know that it is at the very least 50%, and that that it's important that we look at the full burden of RSV in lower middle income countries, and not that previously maybe we were only looking at the partial burden. Furthermore, the majority of deaths occur in young infants, which means the expected impact of RSV prevention is high. And of course, there are several gaps that still remain. One important gap is access to care. So these are children who do not reach the hospital. And we still don't really know why not. Is it a question of parental awareness? So parents who don't recognize signs of severe respiratory distress, or the fact that young infants may have an atypical presentation of respiratory distress. The second, or is it risk perception of physicians who send children home instead of to the hospital? Or is it logistical barriers such as distance to hospital or financial aspects of going to? Second is a second gap is vaccine implementation. So in countries where, or in which a vaccine becomes available, we still need to know more about the countries.
Na katika nchi ambapo
I hear some background noise, but I will continue. We need to know more about the country-specific health economics in lower middle income countries to understand what a QALY may be for a community death which is prevented. We also don't know what the in these populations what the access is to vaccine programs and vaccination, and how high vaccine uptake may be. So I think these are very interesting questions that still remain to be answered for community-related RSV. And finally, I will wrap up with a heartfelt thanks mainly to participating families in this research, also to the Gates Foundation for making this possible, all the collaborators who have done this fantastic work, and the study staff, and also to ReSViNET for hosting this webinar and allowing us to share this with the public. Thank you.
Wonderful. Thank you so much, Natalie. That was really a really lovely presentation, and gave us such a broad and deep understanding of the situation for RSV mortality in the community. I invite all the participants to please post their questions in the Q&A. And while we're waiting for questions, maybe I'll just start with a comment and then a question of my own. So just from the Bill and Melinda Gates Foundation perspective, RSV is a priority pathogen for us, and we are actively engaged in an effort to bring a RSV preventative to low and middle income countries. We have long believed that there has been undetected and under-recognized burden of RSV mortality in the community, and that the RSV mortality burden estimates don't reflect that full burden of disease. And so that was what prompted us to support these various community mortality studies that you so nicely summarized today. I do want to take also a moment from the Foundation's side as well to thank all of the investigators. This is a product of years of work and engagement in the community, as well as rigorous scientific work and laboratory work. And most of all, as Natalie has mentioned, thanks to the family. We have a first question, which I'll now read out. The question is, your findings of high mortality in younger infants strongly supports maternal immunization as an intervention. And so a question about thoughts on that. And I wonder if the question is actually asking about maternal immunization versus a monoclonal antibody approach, but perhaps you can comment on both.
Yeah, I think a very important question and also comment. So if we look at potential interventions such as maternal immunization, which may prevent RSV in the first 3 to 6 months, versus prophylaxis, which also has the target age group of the first 6 months. And what we see here is that the image emerges that both of these interventions could be highly effective in preventing RSV-related deaths, not only in hospital, which we previously knew that the majority of deaths occur in the first 6 months of life, but also in the community where these children may be even younger, but where these interventions will clearly have a high impact. So I think these findings only support prevention and making it available in the lower middle income setting. But also, Padmini, I'm curious to hear your thoughts.
Yeah, I think, I would agree with you. I think that because of the great burden in 0 to 3 months, it actually to us highlights the potential greater impact that prevention approaches would have, because from the data that we know from published trials, even the phase 2b study from Sanofi MedImmune on their monoclonal antibody, that there was a good protection out to 5 months or 150 days given for a monoclonal antibody given prior to the season. In our thoughts for a monoclonal antibody approach, particularly low middle income country settings, a birth dose, I think, would be something that could confer appropriate protection throughout the period of when infants are at greatest risk. And certainly for a maternal immunization strategy, I think the data from the Novavax study, which of course did not achieve registration but did show protection and safety, the greatest protection was seen in the first 90 days of life, which is when the greatest risk of mortality is. So if anything, I think these data highlight and underscore the importance of protection from from what will soon be available, hopefully, to these populations. We have another question. This one actually from one of our investigators, Mauricio Caballero from Argentina. He said, in your point of view, why are the ages different between community and hospital RSV-related deaths, where you showed a younger age distribution in the community-related deaths more so? You're on mute, Natalie.
Thanks. No, I think this is an excellent question from Mauricio. And I'm not sure we necessarily have a good clarification for this finding. I'm curious to hear your thoughts, Padmini.
Yeah, I don't know that that there's necessarily a clear one explanation for this, but I think one of the things you raised is that the presentation of RSV may be also different in the youngest age groups, where presentation with clear respiratory distress may or may not be one of the presenting signs and symptoms, and so may affect the urgency of accessing medical care. I think in many of these communities, the accessibility of medical care is also an issue, whether it is due to availability or to cost, and I think that that in particular, I think is another important contributor. I'm going to actually ask also Louis if he wants to share his thoughts on this.
Thank you, Padmini. I think that age is extremely important to understand potential impact of immunization strategies, and that comorbidities are playing a major role in interpreting these types of data. So if children have a syndrome or a heart disease or a chronic lung disease or something like that, they may be at risk of dying until, I don't know, quite old age, even several years. So I think we also need to interpret these data with some carefully, that the comorbid children are probably need a different approach than the healthy babies. What I still don't know, based on these data, is what is the actual contribution of comorbidities, because even here in the community, there may be different access to these research programs. I think what is striking to me, and I think this is related to this young age, is that apparently healthy babies die in low and middle income countries in the community at very young age. It's something that this is a very strong message to me. If we can save these babies, they may live 100 years just by simple prevention. So this is the impact of this finding is very important. Understanding has probably something to do with comorbidities or risk factors or something like that. It could also have to do with microbiome and other viruses, co-infections, and things that we still need to understand. I think it's still, these are the very, very first studies on community deaths that were done here. Yeah.
Yeah, thanks, Louis. I wonder if you want to take the next question from Zhejiang.
Sure. So I need to go back to the Q&A because I was just so what you're saying, Natalie, is that populations may have an access to care issue as part of the causal chain leading to death. So if access to care is an issue, how are we going to ensure that there will be access to vaccines once they become available? I think this is, I don't know, it's not an easy question, but we would love to hear your thoughts and maybe a voice to what you feel that all of us should do to ensure that this is going to be possible.
Yeah, I wish I had a very simple answer because I think it's quite a complex question, but I think potentially the most important thing that can be done is now in a time where clinical development is very active, that we understand that the need and burden is very high in lower middle income countries, and this research is really one step in that direction, but important steps I think are still missing, such as steps to make sure that regulatory approval will occur in lower middle income countries, but also that people, patients in lower middle income countries will themselves see the need to use a vaccine, as well as key stakeholders, but maybe also physicians themselves. And as I pointed out in my presentation, I think a large amount of research still, we've done some great steps in the right direction to show the importance of vaccine access in these areas, but there are still important questions to answer. And one which has high priority may be, what is the health economic assessment of a vaccine of an RSV-related death which is prevented in the community? What does this give us in terms of qualities? Because that's an essential question for countries to.
I'm sorry, I think we lost you, Natalie. Are you still there, Natalie?
Yes.
Okay, we just missed the last few seconds, so I will. We heard your entire answer. Maybe one final question from my side before maybe Padmini takes another last question. You briefly touched upon poverty when you discussed the Argentina study that living in a slum is important as part of the chain to death. So how does poverty play a role here, not only in Argentina, but also in these low and middle income countries? Is that a given that poverty plays a role in all those places? Is it inequities within those countries, or is it a general poverty issue here? Can you just give us a little bit more of your thoughts?
Yeah, I think poverty, so for example, slums and settlements, what was found both in Argentina, but also in Zambia, that overcrowded households, maybe the mechanism of poverty contributing to RSV may have to do with hygiene and infection rates and co-infection rates, but I think it's not only that. it's also a question, as we see, of predisposition to disease on a physical level, so children that are malnourished and therefore very vulnerable, but also predisposition to disease on a social level, which may have more to do with either care-seeking behavior and education of parents about when is a child really sick, or physicians who may be inadequately trained in terms of risk perception, or inadequately paid in order to do their job, or there may be access, but it may be insufficient. So I think on several different levels, poverty really plays a mechanistic role in RSV-related deaths.
Yeah,
Maybe
thanks,
Padmini, for organization, to finish in time, maybe you can close with a few remarks on these studies,
Sure.
and then I'll close
Absolutely.
the webinar. But maybe you give us your thoughts or look back on this webinar and this series of publications.
Happy to do that, Louis. and thanks, Natalie. I think you underscore a really important point, which is RSV is I think one of the biggest killers of young infants that many people have never heard of or not recognized. And these data, I think, underscore the outsized importance of RSV as a cause of mortality in young infants, and really serve to play a role in both informing updated global mortality burden estimates, as well as can serve as an advocacy tool to work with national programs, to work with public health programs, the larger community, and even healthcare workers to recognize this pathogen. I think there's so much more to unpack here that we could have a longer discussion, but I know we have to close in the next couple of minutes. I think that this has been a really great summary of really critical and I think important data. So appreciate very much the ReSViNET group to organize this. And I'll turn it back over to Louis. I think one of my remaining questions actually was around the role of co-infections, and I think that nicely ties into one of the next ReSViNET webinars that you will be having on RSV and bacterial infections. So perhaps that's a nice moment to turn back over to Louis. Thanks so much, Natalie.
Yes, agreed. Thank you, Padmini, for hosting this webinar, and thank you, Natalie, for giving a wonderful presentation. As translating, we do this for the first time. Can you please inform us what language did you use here? You can vote now. Thank you. I think we can close this one. Can we see the scores? Great. So some of the languages were unused, so we're going to repeat that next time, and if we feel that there is reason to change, we will do so. We analyze this later on. So that leaves me 1 second. I need to thank you for joining us. We will increase the number of languages, and what is important, please inform your collaborators, your staff, your young researchers that this webinar will remain available through our website, and for as long as the website is alive. So please use it as much as you can. Thank you very much for joining us. We highly appreciate your attention, and you all have a great day. Thank you very much. Bye.